right. Good morning, everybody. My name is Ashok Bhasin. I'm the president of Thyroid Federation International. I am based here in Montreal, in Canada, and we have Professor Martin Schlumberger from France with us today. And the topic is going to be low risk differentiated thyroid cancer towards evidence-based use of iodine 131. A brief introduction to Dr. Martin Schlumberger, who does not need really introduction. He's very well known. Professor Dr. Martin Schlumberger is an oncologist at Gustave Roussy and professor of clinical medicine at the Faculty of Medicine, University Paris-Saclay. A researcher and clinical physician, he has been involved in the fight against thyroid cancer for 40 years, making a decisive combination to remarkable progress to find cure. With 10,000 new cases each year in France, this cancer is the fifth most frequent cancer affecting mostly young women. While working as a student with Professor Toubien, a specialist in nuclear medicine at the Gustave Roussy Institute, he won over by the dual clinical treatment approach, which was not so prevalent at that time. There is a lot that he has done in this field, which of course we will talk later. Now, just a few things regarding the Q&A. There is a Q&A section. If you see below, you have to put your questions there. There is no mic going to be provided to anybody for the Q&A. We already have some questions that we have received, but put those questions through. And before I proceed further, I wanted to thank Ipsen and Exelixis Pharma and also Visualizing Ideas, who is hosting the show for us from Basel, Switzerland. So without any further ado, welcome aboard Professor Dr. Martin Schlumberger, and the platform is yours.
Okay, so thank you, Ashok, for this nice introduction. Thank you, Thyroid Federation International, for inviting me this afternoon for this discussion. And also thank you, Beat Barthès and Vive Sans Thyroïde, the French organization, for their long support in all our research and other works. So this is really dedicated to this, to all these patients from Vive Sans Thyroïde and Thyroid Federation International. So my topic today is toward an evidence-based use of radioactive iodine in low and intermediate risk differentiated thyroid carcinoma. And this would be mostly based on the experience gained in France, but also in other centers, and mostly in France in Gustave Roussy. And you have probably noticed that Gustave Roussy was ranked third in the Newsweek classification of cancer centers last week, just after the Memorial in New York and MD Anderson in Houston. So next slide. So I have no relevant financial relationship, and all these prospective trials would be the basis of my talk today, were supported by official grants from the French National Institute of Cancer. Next slide. So in, let's say 40 years ago, there was this study by Ernest Mazzaferri, who was a leader in the field of thyroid carcinoma, and who was shown on a limited number of patients in retrospective studies that the use of radioactive iodine postoperatively associated with long-term thyroxine treatment decreased the risk of recurrence in patients with thyroid cancer larger than 1.5 centimeter in diameter. Next slide. Next. So this led to the old dogma of treating patients with total thyroidectomy, followed by ablation with radioactive iodine, and followed by T4 suppression of TSH secretion. This was recommended by Mazzaferri for extended disease, or at least for tumors larger than 1.5 centimeter, but was applied to many patients, to the majority of patients in some centers. Next slide. So this was one point. The other point was where data obtained at the Mayo Clinic, where the use of radioactive iodine was limited to a very low percentage of patients. Less than 5% of all thyroid cancer patients received post-operatively radioactive iodine. And despite of this, most of the patients had excellent survival with death-related mortality of less than 1 to 2% in over 80% of patients. Next slide. And also one fascinating report from the Mayo Clinic was the fact that even in a patient treated with radioactive iodine in low-risk PTC papillary thyroid carcinoma, the risk of recurrence, local or regional, or distant metastasis was not decreased by the use of post-operative radioactive iodine. Next slide. So we had two opposite attitudes. One is from many nuclear medicine experts and some thyroid experts. They who stated that an ablative dose of radioactive iodine should be given to all low-risk patients for the certainty and peace of mind provided by a subsequent negative scan and undetectable serum TG concentration. And with my friends Filetti and Jan Hay, we stated 20 years ago that in contrast to this statement, that radioactive iodine should be used post-operatively only selectively, and that not all patients with a diagnosis of follicular cancer-derived carcinoma will benefit from routine post-operative radioactive iodine therapy, especially low and intermediate risk patients. Next slide. So now, if we look at the spectrum of thyroid carcinoma in the world, there is an estimation of almost 600,000 new cases of thyroid cancer cases in worldwide. And for these patients, there is a consensus concerning very low-risk tumors, I mean micropapillary carcinoma, or small, very small papillary carcinoma with no lymph node metastasis. And there is a consensus that these patients should not be treated with radioactive iodine, and some should not be treated at all. So there is also a consensus in the small minority of patients with high-risk tumors, with large tumor, with extension in the neck tissues, with large lymph node metastasis. And for this patient, a high activity should be given for adjuvant treatment or treatment. But there are still controversies concerning low and intermediate risk tumors that represent over 80% of cases. Does ablation of normal residual thyroid tissue and or treatment with radioactive iodine improve the outcome? And this is the topic of my talk. With these controversies, there is a dilemma for doctors of treating or over-treating patients, and for patients who may ask for a treatment in order to supposedly decrease the risk of recurrence. So there is anxiety on both parts. Next slide. So the definition of low-risk patients are patients with stage 1 or 2 TNM with a very low risk of cancer-related death, less than 2%. They represent more than 90% of cases, and high-risk patients who present 5 to 10% of cases are stage 3 and 4. Next slide. The other endpoint in cancer is the risk of structural recurrence. And there is this American Thyroid Association stratification, which was published in 2015 with in the guidelines, it's American Thyroid Association guidelines, and which classifies patients as low risk with a risk of less than 5%, intermediate risk with a risk of recurrence of 5 to 10%, or high risk with a risk of recurrence higher than 10%. And next slide. So we have a group of patients, low intermediate risk patients who are cured after surgery alone with a risk of cancer-related death of less than 1 to 2%, according to TNM classification, and a risk of persistent recurrence disease of less than 5 to 10%. In the American Thyroid Association guideline, there are 28 recommendations for initial treatment. And in this guideline, it appears that low-risk thyroid cancer patients should not be exposed to postoperative radioactive iodine. But only one recommendation out of these 28 is with a high quality of evidence. It means that the others are poor or medium quality of evidence. And despite these guidelines, it appears that in 2022, about half of the low-risk patients in the US are still treated postoperatively with radioactive iodine. Next slide. So the problem is to provide convincing data on treatment efficacy. And this Ernest Mazzaferri, this expert in the field, asks the question, why does all this controversy exist? Clearly, the most important reason is the lack of prospective trials. For these patients, low and intermediate risk patients, there is no demonstrated risk of a single postoperative administration of radioactive iodine, but also there is no demonstrated benefits. And as already reported, the absence of convincing data may increase patient anxiety concerning the risk of recurrence and may lead to overtreatment. Next slide. So we started 25 years ago to try to provide convincing data on treatment efficacy. And for these trials, these were only academic trials because no support could be obtained from the industry. So this needs methodological and financial support from official sources. This needs a large number of patients to be accrued, well-defined patients from a large network of centers and with the support of patient association. So these trials were feasible thanks to this strong support of patient association. And this need a continuous effort during long periods of time because the answer will be obtained only after 10 years or even more. And finally, this needs successive trials and each answering a question. Next slide. So it's quite complicated. So we have performed successive prospective trials since 25 years. Starting with the definition of excellent response to therapy, avoiding control with radioactive iodine total body scan, avoiding stimulation with recombinant human TSH, and using neck ultrasonography and sensitive thyroglobulin determination on thyroxine treatment. And then we have performed, starting in 2007 and 8, this Estimab-1 study, and then in 10 years later, the Estimab-2 study, which we'll detail later today. So next slide. So this first randomized trial ever performed in low-risk thyroid cancer patients addressed the strategies of radioiodine ablation in patients with low-risk thyroid cancer. There were two very similar studies, one performed in France and the other one performed in the UK, and we reached exactly the same conclusion. So these two trials were published in the same issue of the New England Journal of Medicine 10 years ago in May 2012. Next slide. So the question of these two studies were which is the right protocol to be used for ablation in these low-risk thyroid cancer patients. One parameter was TSH stimulation, use of recombinant human TSH or prolonged withdrawal, and the other parameter was the activity of radioactive iodine to be administered, low or high. So we had 4 groups with a combination of these two parameters. Next slide. And the endpoint, the main endpoint was the ablation success with each of these combinations. And we observed that after 6 to 10 months after ablation, 92% of patients were totally ablated with undetectable serum TG and normal naked ultrasonography. And this percentage was similar in all groups of patients with recombinant human TSH 30 millicuries or withdrawal 30 millicuries, recombinant human TSH 100 millicuries or withdrawal 100 millicuries. Next slide. The main advantage of this study was to show that the use of recombinant human thyroid stimulation hormone, like Thyrogen, maintains the quality of life during ablation, whereas using withdrawal, there was a decrease in the quality of life for almost 3 months. So this was an extremely important parameter, and other parameters were the lack of the decrease in the radiation dose delivered to the body and the well-being of patients. Next slide. So this was the results of the Estimab study, the French protocol on 752 patients, and the HILO study on 438 patients performed in the UK found exactly the same results with no difference between the 4 groups of patients. Interestingly, patients in the HILO study had more advanced disease, more aggressive disease, or at least half of these patients had more aggressive disease than patients in the French study. Next slide. So this led to a modification of the label of EMA and FDA approval, which stated that the recombinant human TSH Thyrogen can be used in combination with a range of 30 to 100 millicuries of radioiodine for ablation of normal thyroid tissue remnants. So this was a modification because previously 100 millicuries had to be administered, or 100 millicuries or more had to be administered if Thyrogen was used. Next slide. Then the other parameter which is important is the long-term outcome in these patients. So we followed all these patients for a mean of more than 5 years, and no thyroid cancer-related death was observed. In almost in the large majority of patients, 700 out of 711 patients, there was no evidence of disease, absolutely no evidence of disease. And there were some abnormal findings in only 11 patients, 1.5%. So it means that even with a low activity of radioactive iodine, the large majority of patients were cured and did not experience any recurrence. Next slide. So these are, previous one. Yes. So these were the 4 groups of patients where there were no significant difference in the number of abnormal findings among all these groups of patients. And also, which is an important parameter, there was a similar number of treatments administered during follow-up among these 4 groups. Next slide. Next. So the ILO found exactly the same. Next slide. With a similar number of events occurring in all 4 subgroups of patients. And there was no more recurrence in the 30 millicuries, 1.1 gigabecquerels following Taurogen compared to the other 3 groups. So this was extremely reassuring. And from this, next slide, we selected in low and intermediate risk patients the protocol using Taurogen and 30 millicuries, 1.1 gigabecquerel for ablation in low and intermediate risk patients. The question was then, is this radioiodine administration beneficial for patients after total thyroidectomy? And this was the topic of this second prospective randomized trial published in March of this year, also in the New England Journal of Medicine. Next slide. So there were 2 groups of patients, one treated with Taurogen and 30 millicuries, and one with no radioactive iodine at all, only follow-up. And it was a non-inferiority trial, and this trial was positive if the difference of less than 5% was observed in the proportion of patients without any event 3 years after randomization. And the definition of events was the abnormal foci of radioactive iodine uptake on post-therapy scan, abnormal neck ultrasonography during follow-up, or elevated TG or TG antibody levels. Next slide. So again, more than 750 low-risk thyroid cancer patients were included in the trial for 35 French centers and were randomized into 2 groups with an equal number of patients. You may note that most of the patients were T1B, so more than 1 centimeter in diameter, or T1AM with multifocal micropapillary carcinoma. Most of these patients were N0, but multifocality was observed in 43% of patients. Next slide. So this is main results observed at 3 years after randomization, and there was a non-inferiority of this treatment with no radioactive iodine compared to the treatment with 30 millicuries following Taurogen. 95.6% of patients who did not receive radioactive iodine had no evidence of disease at 3 years, compared to 95.9% of patients who received radioactive iodine. So the difference was 0.3%, which is far below the 5% requested for non-inferiority. So what we also observe is the quality, anxiety, peace of mind were not altered in patients who did not receive radioactive iodine. There is another trial in the UK, very similar to this ESTIMA-2 trial, and results are expected soon, and I hope that they will confirm these data. Next slide. So we have looked for risk factors for recurrence or event during early follow-up. And the most significant was an elevated serum TG on T4 treatment at randomization. It means after surgery, but before the administration of radioactive iodine. And theirs increased by a factor of 5 when TG was above 1, compared with a patient with a TG below 1, or a factor of 3 when TG was above 0.5. Next slide. So we have this protocol now in Villejuif for patients with radioactive with thyroid carcinoma operated with total thyroidectomy, no radioactive iodine in low-risk patient, PT1A, PT1B, N0 or minimal lymph node metastasis. In patient with PT1, 1, 2, 3, and N1 according to the location, number, size, extracapsular extension, administration of radioactive iodine, and for patients with PT4 or large N1 or distant metastasis, 100 millicuries, 3.7 gigabecs, and following thyroid hormone withdrawal. So this, I think, is very easy, but most of the patients now are low-risk patients and should not receive radioactive iodine. Next slide. So the conclusion of all these studies is that low and intermediate risk patients, PT1, N0, NX, without structural disease after surgery, there is no difference in the rate of abnormal findings at 3 years. In 80% of patients with post-operative radioactive iodine administration is not indicated, and this can be administered selectively in the few patients with a significant risk of recurrence, including patients with elevated serum TG or elevated TG autoantibodies. The alternative of this administration is a close follow-up and the administration of a higher activity in case of recurrence. But again, recurrence is extremely rare in these patients. Next slide. Now, recently in the European Thyroid Journal, a retrospective series from the Mayo Clinic showed that according to the number of lymph node metastases, there was no obvious benefits in administering radioactive iodine post-operatively after total thyroidectomy. The curve in black is surgery alone, and the curve in red is surgery plus radioactive iodine. And as you can see, there is no difference in the outcome of this patient according to the number of lymph node metastases found at surgery. Next slide. So a few words for acknowledgement of the importance of the contribution of Beat Barthès and Viv Santireit. It is really a win-win strategy. And I think that the other patient association in the world could do exactly the same. participation in the definition of unmet needs, in the design and endpoints of the protocol. So this is extremely important to get the adhesion of patients and of the association. This participation is key for the success of prospective trials, because these trials on low-risk patients need a large number of patients, 700 or 500 at least per trial, with a long follow-up, with no loss to follow-up. So they can receive information of preliminary results and have frequent meetings with experts. I remember that in this past year, I had a meeting with VIV Centiroid patients at least twice a year, and benefits from the conclusion of the trial are for me obvious. Radioactive administration can be avoided in at least 2/3 of patients without any increasing risk of recurrence. And this will save time, stress, expenses, irradiation, will improve the quality of life, and the peace of mind is provided by high quality data. There is no increased risk of recurrence. Next slide. So there are still problems requiring solutions for thyroid cancer patients. Access to patients to appropriate diagnostic tests, therapies, and expertise. And we should promote and ensure participation of patients in understanding their needs, decision process about their diagnosis and treatment, organization of patient care, organization and execution of scientific research, and preparation of information material. Availability of high quality data obtained in prospective trials are extremely important to educate physicians and change attitudes, and empower and educate patients. And finally, to improve doctor and patient communication. Next slide. So, general conclusion, randomized trials are feasible in low-risk thyroid cancer patients. We should perform academic prospective trials rather than retrospective studies. We should involve patient association. European Union Beating Cancer Plan may provide support, and there are still many prospective trials in France in low-risk patients, prophylactic central neck dissection versus no prophylactic central neck dissection. So this is a surgical trial. And in intermediate risk patient, post-operative selection with diagnostic total body scan versus routine radioactive iodine treatment. And this is an ongoing trial. The PI, the principal investigator in Stéphane Bardet in Caen, and the TUTIREF network is actively participating to these two trials. I know that in the UK, there are other trials, such as ION, which is very similar to Estimable-2, and a trial comparing the outcome after lobectomy versus total thyroidectomy, and probably many others. Next slide. So thank you for your attention, and I am ready to answer all your questions, if possible. Thank you.
So we have a couple of questions, but before we go into the questions, some of the things that I just wanted to tell you. Those of you who have joined a little bit late, don't worry about it, because this is going to be available on our webinar, which is going to be on the Thyroid Federation International YouTube site, and we will send all that information to you, so not a problem. Again, just a reminder that this is part of our Thyroid Cancer Month, which is September, and this is brought to you by Thyroid Federation International. And Beata, thanks very much for getting Dr. Schlumberger on with us, and he's really done a great job. By the way, Dr. Schlumberger, we have Secretary of ETA, Dr. Leonard Dantes, and Secretary of IOTA, Dr. Feridul Alam, also on site with us on this. And we have people from Asia, we have people from Europe, we have people from North America and South America on this call. So, I will now get into the questions. And Dr. Leonidas says, thank you. Okay, excellent talk. That's what he says. And also Dr. Faridul Alam, who's the secretary of IOTA, says, excellent presentation, learned a lot in my country. Patients come late and risk stratification is not well done. So those are some things. Now, coming to some questions, and I will address Dr. Derek's question also. So Derek, don't worry about it. We'll come to your question also. We have that, but I'll just go by sequence. One of the first questions that we got is low risk 1 centimeter PTC, but persistent TGAB more than 1 year after thyroidectomy. Is this indication of ablation?
So this is a real and frequent question and problem. From this ESTIMAB-2, there is no demonstration that administration of radioactive iodine is useful in these patients. So my feeling and my personal attitude is to follow these patients on thyroxine treatment and observe the trend of TG level over time. If there is an increasing trend, if the TG levels increase over time, then probably there is a need for other treatment modalities, such as administration of radioactive iodine. But if the TG remains stable or decreases with time, there is no need for any treatment. So I would select a patient with a significant increase, significant elevation in TG level after some months or years after surgery, based on the trend of TG level over time to administration of radioactive iodine. Is that clear?
Yeah, okay, so the next question is low risk patients not treated with RAI, what is the method of follow-up since TG levels may not be reliable?
So I disagree with this. It depends on the quality of total thyroidectomy. If the total thyroidectomy is really total, TG will become undetectable in the large majority of patients, or will be extremely low, let's say below 0.3 nanogram per ml. Now, if the thyroidectomy is partial, may be called total, but in fact partial, with large thyroid remnants, then the TG may remain detectable, and you do not know from which kind of thyroid tissue it comes from, tumor tissue or normal thyroid tissue. So again, in these patients with detectable serum TG and with not total thyroidectomy, there is two ways of managing these patients. You can observe the TG level over time and treat the patient with radioactive iodine if the serum TG increases over time, or if the serum TG is low or decreases over time, then you just have to follow these patients. So this is obviously in case of normal neck ultrasonography. In case of abnormal neck ultrasonography, this is another problem.
Okay, so next question we have from Mehdi, and his question is ESTIMAB-1, why exclusion of patients with persistent structural disease? And did that not affect results in a biased way? Please explain. And the next question also is in the same thing, is the ESTIMAB-2 cohort really a low intermediate risk group, or rather looks like a very low risk cohort?
The aim of ESTIMAB-1 was to study ablation, not treatment. So ablation of normal thyroid remnants, okay? And to study the ablation rate, we had to exclude patients with structural disease after surgery. So this is the first point. The second point is that in Estimab-2, we had a lot of discussion at the beginning because many nuclear medicine doctors, specialists were reluctant not to give radioactive iodine to intermediate risk patients. So to have a kind of a general consensus agreement between potential participants and doctors and also patients, we decided to start with low-risk patients. It means patients with T1AM, small, less than 1 centimeter, but multifocal, T1B, 1 to 2 centimeters, uni or multifocal. All these patients were N0 or NX, and 43% of these patients were at multifocal disease. So this can be classified as low-risk patients. So this was the first attempt to show that radioactive iodine is useless in low-risk patients. And I think this data were needed. The ION, the British study, has included many more patients with intermediate risk cancer, and we will see the results, but I'm very confident that they will show exactly the same as we did. And furthermore, the intermediate protocol managed by Stéphane Bardet addressed the question of whether radioactive iodine should be given to intermediate risk patients. So we started with low risk patients, and this will be expanded to low intermediate risk patients and finally to intermediate risk patients.
Okay. Another question.
So, so this is the occasion to say that to patients and to patient association, please accept inclusion of many patients, promote inclusion of patients in these prospective trials, because the only way to get good quality data is to have results from well-designed prospective trials.
Good point. Thank you. The other question is from Naima, and Naima says, will you consider doing diagnostic I-131 scan prior therapy for low-risk patient who might be candidate for I-131 therapy, for example, PT2?
So this is the topics of the intermediate trial managed by Stéphane Bardet. Patients are randomized between with intermediate risk, randomized between radioactive iodine directly or selected with a diagnostic radioactive iodine total body scan and treated only if there is some abnormal findings.
Okay.
So
another question is from
you have Mohammed. To wait. You have to wait for the answer for I don't know for 5 years. Yeah.
Should I go ahead?
Yeah.
Okay. Another question is from Mohammed Howry. Does the trend of TG antibodies matter as well as TG itself?
Well, this is a good question, and I'm not sure that there is a definitive answer to this, but probably if you have an increase, a large increase in TG titer, it should raise some anxiety. But if you have a decrease in the anti-TG titer, this is a good symptom. But I am still a little bit reluctant to to consider TG antibody titer as the only parameter used for follow-up. So if there is anti-TG antibodies, TG determination is not perfectly reliable. So I would do other tests, starting with a neck ultrasonography and following this patient with neck ultrasonography frequently.
Okay. Can we go to the next question?
Yep.
Yeah. So the question is from Francisco Peroda, and that is, what is your opinion about TOETVA? TOETVA. TOETVA.
I don't know. I have no opinion.
Okay. Another question is from Khalud Al-Riyami. Are the patients who do not receive RAI followed up more closely compared to those who receive it?
Well, you know, we decide not to treat not to give radioactive iodine based on prognostication. And patients who are not treated with, or who do not receive radioactive iodine are by definition very low risk patients with a very low risk of recurrence and an even much lower risk of thyroid cancer related death. So when the risk of recurrence is extremely low, there is no need for active surveillance every 3 or 6 months. I think that what we do is to we start thyroxine treatment after surgery. We control TSH 3 months later, and then on a yearly basis with neck ultrasonography at 1 year, and then serum TSH and serum TG determination, and that's it. Once a year.
Okay. Another question, Martin, we have is on potassium iodine distribution. And, you know, what do you think about its use as prophylaxis in affected areas with radiation?
So there is a threat in Ukraine of a new accident, nuclear power plant accident. So I can tell you what we have done in France. In France, pills of potassium iodine have been pre-distributed within 20 kilometers from each the 19 nuclear power plants. So it means to 2.2 million population, 2 pills per individual. Okay. In case of a nuclear power plant accident, the problem is when potassium iodine should be taken. The optimal time is a few hours before the contamination. So it is useless to take potassium iodine, for instance, 2 days after the contamination. It should be taken 1 or 2 hours before the contamination. And the signal to take it should be taken by the public authorities when there is an estimation of the dose which will be delivered by the radioactive iodine in the atmosphere, which will be over 50 milligram. So in this case, children and pregnant and lactating women should be given potassium iodine in priority. And then adults of less than 45 years should also receive potassium iodine. And this is extremely effective because if the potassium iodine is taken in large quantities, 1 to 2 hours before the contamination, it prevents the uptake of radioactive iodine in the thyroid gland by more than 98%. So it means that even if the body is contaminated, the thyroid will not concentrate the radioactive iodine and will not be irradiated. And this will prevent thyroid irradiation and then the development of thyroid carcinoma later in the life of these children. So I think that there was an experience in Poland immediately after Chernobyl, where 18 million population received potassium iodine. The dose to the thyroid of Polish people was maintained in all cases below 50 millisievert, and there were extremely few side effects. Extremely few. I think there were only 3 hospitalizations, and even in newborns, there was no damage to the brain development of newborns. So I think this is a safe measure and extremely effective if performed correctly. But, you know, we have, during the Chernobyl, there was no potassium iodine distribution in France, for instance, because the radiation dose brought by the cloud, the radioactive cloud over France was extremely low and was not hazardous. And there was no potassium iodine distribution in Japan after the Fukushima disaster, because the dose, the projected dose to the thyroid of Japanese people was also extremely low.
Okay. Now, Doctor, the question which was, what is your opinion of TOVITA, has been clarified by Francisco Perrotta. It says, what is your opinion about transoral thyroidectomy?
Oh, excuse me, I was not on this. Well, just to speak frankly, if I had to be operated of the thyroid, I will do the classical way with a scar at the bottom of the neck. And I have done this some years ago, and it's really, as an outpatient, it's really not extremely easy and very well supported, absolutely painless when done by a good surgeon. So I am a traditionalist, and I think that all these ways of performing a total thyroidectomy through the axilla, through the mouth, behind the ear, can be used in patients who do not want to have a scar in the neck, but this is, from my point, the main advantage, which is not sufficient to convince me, if I had to be operated through one of these ways.
Okay. Now, you know, about the mental connection, you know, with Derek's question. What is your answer on that?
About the what?
The question that I had sent you from Derek. Yeah. You know, he says, what is the mental connection with all this? You remember the question I sent you?
Yes, but I have well, my feeling, I don't know if this will answer the question. My feeling is that if we, I mean, doctors, care providers, and patients can rely on data, good quality data, then the anxiety of being treated by one way or the other will disappear. I think that our problem with thyroid carcinoma is that up to now, there were no good quality data. So if a patient sees one care provider who say you should do it, and another one who say you should not do it, and then he says, why should I do it? And why should I? And there is no definitive answer, this may raise anxiety. Now, if you have good quality data, there is no alternative. You should do what the good quality data tells you to do.
Okay. So thank you very much. We are almost at the close, and the Professor Dr. Schlumberger, thank you so much for taking this. And Beata, thank you so much for helping to get Professor Schlumberger. He is fine. He's looking great, and it's really good to see him looking fantastic and great after what he went through. So Dr. Schlumberger does not talk theory. He talks from practical experience too. So, he has the practical experience too. Once again, this was brought to you by Thyroid Federation International. And we thank Ipsen and Exelixis, who are supporters of this. And this is the Thyroid Cancer Month, for September month. We will do this every year and each year. And thanks to each one of you for joining. And again, it was an excellent webinar. We will keep this webinar on TFI, which is Thyroid Federation International YouTube, where everybody can watch this and take advantage of it. So those of you who joined late can definitely go and have a look at it. And if ever you have any questions, please do send it to us, and Dr. Martin Schlumberger will be happy to answer that. So thanks again to all of you for joining. Thanks again to Thyroid Federation International board members and all the members. And it was great, and thank you for your valuable time. So much time goes in preparing and delivering the lecture. We really appreciate, Martin, for all that you have done. And
thank you.
That's all
thank
for
you,
now. And thank you very much. And we should have more webinars, and we will be in touch. And thanks for joining again. Bye for now.
Thank you.